My name is Alan Pitt. I'm an informatics physician and have worked with the International Diabetes Center as well as others interested in the disease for the past several years. Diabetes remains one of our three most pressing health problems. It is somewhat unique in that it puts a daily burden on the individual for management of the disease with a promise for decreased complications decades away. It is also a very data-rich disease, but there is little in the way of technology tools to enable the person with diabetes to participate in their own wellness. I believe there is an opportunity for a diabetes community to be built around the patient, but providing opportunities for all those interested in the affliction to participate. For me, change in healthcare really focuses on three pillars. First and foremost, the patient needs to be empowered. The government has promised all providers an electronic medical record. This focuses on the apex rather than the base of the pyramid of healthcare. Why not give patients the tools they need to monitor their own disease? I have a PDA to schedule appointments, give me reminders, etc. Where's the patient's PDA? Next is the continuum of care. If information is not present at the time of care, it's really worthless. Today, interoperability is largely a shoebox for patients. They keep their records in the box in hopes their care provider will open the box and figure out the next course of action. Healthcare solutions need to go beyond the 1950s and have meaningful dashboards of relevant information. Finally, we need outcomes. It's very difficult to make meaningful decisions about care one patient at a time. Time-honored traditions and experience are great, but these results need to be constantly measured for process improvement. When one talks about any solution, there's always a worry of patient engagement. Will they use it? I would note most of us do not care about electronic medical records. We simply care about being well. For me, an ecosystem involves far more than the patient. Each of these circles represents a vested party, a separate group interested in the wellness of the patient. Each of these needs their own opportunity to participate in the process. All of this needs to be outcomes-based. If we do something to the patient, ask something of the patient, doesn't lead to a meaningful difference in a quality of life. This needs to be measured over time with large numbers of participants. Engagement is currently a controversial concept in the diabetes community. Is it the patient who won't engage, or is it the provider who doesn't have the appropriate skill set to educate the patient as to best practice? There's a lot of finger pointing at national meetings. Frankly, we really shouldn't care. The only thing that matters is the outcome. How is the patient, how is the community doing with the care that's provided? Relevant outcomes allows views of the patient over time, the provider's practice, a particular community of patients. We don't really care why a particular provider's patients aren't doing as well as the provider down the street. We just want to identify what is working and what isn't, and constantly strive for the best outcomes for all. I'm an advisor to a small company, Emerge MD. This company is somewhat novel in providing patient communities for nearly a decade. The basic functionality includes dynamic registration, a profile on the patient based on information the patient provides over time, the ability to communicate with the patient repeatedly and in a way that they're comfortable with, be it paper, digital, or text, and then the ability to report on outcomes by patient, provider, or community. This incorporates repeated communications with outcomes-driven alerts and reminders. For a community to be successful, there are really three things. There's the self-interest of the patient to maintain wellness, best practice. In this case, the content was based on work by the IDC and a technology framework. Using this framework in other disease states, we've seen up to a 90% engagement at 3 years, 50% at 10 years. So in summary, what we're really trying to do here is care for the individual, but allow data roll-ups to be provided for outcomes around the community. This is the landing page for the Diabetes Registry. It's a smart form which essentially allows a 30 to 40 page document to be completed in 12 to 15 minutes. This is built on Web 2.0 tools. It builds an initial profile of the patient for personalized care and education. It can be presented in a language the patient is comfortable with, but reports the information in English in the background. I would note that we're focused on collecting data from home as opposed to hospital or clinic visits. Patient-reported outcomes are a key metric that are currently not included in clinical care and research. I would note, however, that forms for educators, clinic visits, hospitalizations could be added to this continuum of care. We have done this for other disease-specific communities. Data entered over time needs to provide real-time feedback. What is going well and what isn't going well. In this case, you can see the green and arrow and red highlights. This allows for support and affirmation during the process. Of note, one of the major failures of many disease management programs is a lack of transparency. Reagan used to say, "Trust but verify." In this case, the patient can be incentivized to participate, but their level of participation can be monitored. The payer might incentivize the patient to participate at the beginning of the year, but if a certain level of engagement isn't met, they may not want to do so. If the patient falls below a certain milestone, there can be reminders during the year to keep them on track. Another major hurdle in disease management is personalized information. Search on the internet is clearly too much of a good thing. Information needs to be tailored to the patient. These are search fields that allow the community to be separated into distinct groups. In this way, a patient population can receive information that is relevant to them. This can be by a new participant, anorexic, poorly controlled, by region, by payer, etc. Personalized messages can be sent out. I would note that information within a community can have powerful implications. When I was at the IDC, I met a man whose wife and daughter both had diabetes. He would call his daughter, who now lived away from home, at least once a week at late at night, "Are you okay?" She would always be bothered by these calls. It was an invasion and a reminder of her diabetes, but he was worried and she had slipped into coma in the past. In this case, the patient collects information about themselves, and only if there is a problem is the family or friends notified. This allows the patient to keep their independence while the family has peace of mind. This care cycle extends beyond diabetes to other problems. Imagine an elderly patient who is asked somewhat simple but frequent questions, and as long as these are correct, the family is not notified. You can also note that information can be used by the care provider, by the individual themselves, or by the individual to compare themselves against peers. This is an example of reporting around an individual. Here's another example of reporting around a group. Here's an example of reporting of an individual against a group in the case of diabetes. In part 2, I'm going to talk a little bit about collaborative care and its possible role in diabetes. Thank you.